So let's have a look at some more cases. It won't just be lifespan study people, atomic bomb survivors, but there's a few other sources of radiation, radiation sources as well in the following slide. So we'll look at a few: thyroid cancer, leukemia, bone cancer, lung cancer, breast cancer. So risk estimates here are given in the number of cases expected if 1 million people were given 10 millisieverts of dose. So let's look at radiation-induced cancer. Oh, that's a repeat of the previous slide. Okay, so let's have a look. Thyroid cancer. So some risk estimates have been derived based on data from atomic bomb survivors and Marshall Islanders. So here's the Marshall Islands here in this map here. So here's where there were a number of nuclear tests undertaken, and people lived around these islands. And what was happening was between 1946 and 1958, there were they would set off nuclear weapons in here, and there would be radiation fallout coming across to the people living in these islands. So they were receiving additional dose. And there's no data here. So that was the Marshall Islanders. We're also looking at atomic bomb survivors, and then they're also looking at radiotherapy patients. So this again, we're still looking at thyroid cancer. So children treated for an enlarged thymus. The resulting known risk estimates for radiation-induced thyroid cancer are 50 to 150 cases induced per million people per year exposed to 10 millisieverts. Or, so that's cases induced, or actual deaths is 8 deaths per million per year exposed to 10 millisieverts. So that's how we're going to set out the statistics for this as we go through. So here is the different groups of people, and so this is the incidence of thyroid cancer. This is set as a percentage, and this is the dose received. And what you can see is we've got a data point here, a lower dose, a data point, a high dose, and a data point at a high dose. I'm not sure which group got which here, so I can't tell you what. But then we have the linear no threshold model fitted to that. You can see again huge error bars there. So yeah. Alright, so that was thyroid cancer. What about leukemia? Most of the information comes from survivors, atomic bomb survivors, but there are other things. People treated with ionising radiation for arthritis. Some treated with ionising radiation for hypothyroidism, so hyperactive thyroid gland. So this will be done with iodine-131, and it results in a bone marrow dose of about 0.1 gram. So there was a study of 36,000 patients treated with iodine-131 therapy, and it showed an increase in the incidence of leukemia. However, a similar increase was noted in patients who had the thyroid surgically removed, but who did not receive the iodine-131. So this study may be questionable, and perhaps there's some other factor involved. The best risk estimate for fatal leukemia from exposure of the bone marrow is about 50 deaths per million per year exposed to 10 millisieverts. Here's the data. This is the atomic bomb survivor data. So we've got Hiroshima and Nagasaki here, and you can see that we have the data fitted. Again, very large error bars, and we have the linear no threshold model fitted to both of these. There is a difference between Hiroshima and Nagasaki in that Nagasaki, I believe, had a much higher neutron incidence, neutron dose, because it was a different type of bomb. Okay, let's have a look at bone cancer. So the main group to study here are watch-style painters, and we'll go through this in a later lecture when we do epidemiology. But these were the female factory workers in the early 20th century, and they used to paint radioactive paint or for glow-in-the-dark watches to watch faces and aircraft instruments. Normal incidence of radiation-induced bone cancer is very rare, but in 800 watch-style painters, there were 72 cases observed, and they did some studies, and they estimated that they got between 0.5 and 500 gray. Again, we'll cover this in a later lecture, but basically what they were doing was getting the paint all over themselves and actually swallowing it. So it was going to them. So the risk estimate for this is 5 deaths per million people per year exposed to 10 millisieverts. Here's the data here, and we have our linear no threshold model here, and we can actually see that this follows not what we expect for the linear no threshold model. Maybe it goes like that. I suspect not. It probably goes more like that. And possibly because this is maybe the measurement of the dose was incorrect, because this was a bit of guesswork. So maybe these things like go that way and that way and that way. It's all a little bit uncertain. Okay, about lung cancer. The estimates for lung cancer come from studies of uranium miners who breathe uranium dust. In particular, until the early 1900s, 50% of pitch blende work miners, so pitch blende is uranium miners basically, in Bohemia, died from lung cancer. The risk estimate for more recent studies is approximately 85 per million per year exposed to 10 millisieverts. But if you look at these guys, there's other factors. What about the fact that these are miners, early 1900s in Bohemia? They were probably all very, very heavy smokers. What about breast cancer? So there's several groups for this. So there's patients treated with metastasis, mastitis, I should say, to the breast. So dose to the breast was 1 to 10 gray. These are atomic bomb survivors, so there are 12,000 women. And there were female patients in a Canadian sanatorium who got multiple fluoroscopies for tuberculosis. Some of them got as many as 500 fluoroscopies per patient, which is a huge amount. The risk estimate for breast cancer is about 20 cases per million per year exposed to 10 millisieverts. The overall risk of radiation-induced cancers are the best documented, or these ones that we looked at are the best documented, but there's other studies as well, and they keep coming in. The total risk of death for not ionising radiation is about 500 per million of the general population exposed to 10 millisieverts. For radiation workers, so that's the general public, for radiation workers it's 400 per million per year exposed to 10 millisieverts. The reason is radiation workers tend to be healthy, because if you're a worker you have to be healthy to be working, and you're in the working age, so you're not too young, not too old, and so therefore a radiation worker tends to be a little bit healthier basically. Still uncertain if, okay, sorry about these slides. Still uncertain if there's a threshold for the induction of cancer. But we'll just be prudent and assume that there is, that there's not, so that we don't say, yeah, okay, let's give everybody a little bit of radiation when then perhaps we don't need to. The effect of the dose rate is not known, but high dose rates tend to be more effective in inducing cancer, and the effect of LET is not quite fully understood yet. In the context for radiation protection, looking at stochastic and deterministic effects, the radiation protection is set up so that we want to prevent deterministic effects, except for when we actually want to induce deterministic effects, and we want to reduce the probability of stochastic effects, so we keep the risks low. And that's all for this week. Don't forget the online quiz, and that's all.